Good afternoon, everyone. My name is Eric McDonald. I'm the Chief Medical Officer for the County of San Diego Health and Human Services Agency. And we're here today to discuss COVID-19 medical and health misinformation. This session is being simultaneously translated into Spanish. And there is a globe at the bottom of your screen that you can check on, and you can select Spanish if you want to listen to this simultaneously in Spanish, and this will be available afterwards also in Spanish. I'm very pleased to be joined today by four local medical experts for today's discussion, and they are Dr. Nettie Aldis, the Clinical Director of Infectious Disease at San Ysidro Health. She just waved her hand. She received her medical degree from UCSD, completed residency in internal medicine at the University of Colorado Hospital, and returned to UCSD for her infectious disease fellowship. Dr. Aldis has a career focus on health disparities in historically underserved communities and serves as the director for the San Ysidro Health programs in HIV, tuberculosis, infectious disease, and gender-affirming medicine and sexual health. Dr. Aldis is a member of the San Diego County COVID-19 Equity Task Force and also the county's Testing Task Force and the Vaccine Clinical Advisory Group. So thank you, Dr. Aldis, for being here. We have Dr. Siu Ming Giri, who is the Vice President of Primary Care at Scripps Clinic in La Jolla, California. She received her undergraduate and medical degrees at UCSD, and she completed her internal medicine residency at UCSD also, and joined Scripps Clinic in 2005. Her areas of interest are in preventive care, population health, medical education, and innovation. She's the chair of the Scripps Clinic Medical Group, Diversity, Equity, and Inclusion Task Force, and she maintains a clinical practice in internal medicine at Scripps Clinic in Rancho Bernardo. We have a member of the panel who is unfortunately going to join us late. That is Dr. Zolma Curet from Neighborhood Health. She is a board-certified pediatrician who's been committed to practicing in Southern California underserved communities for over 8 years. Her medical degree is also from UCSD, and she completed her pediatric residency at LA County USC. In addition to her practice as a pediatrician at Neighborhood Health in Escondido, Dr. Curet is also the co-founder and co-host of the Future Minority Doctor podcast. And last year, she was one of the recipients of the San Diego Business Journal's 2021 Healthcare Heroes Award. And actually, during the pandemic, she's appeared on Univision San Diego several times to educate the Latinx community about COVID and strategies to prevent illness. And our fourth local expert is Dr. Mark Sawyer, who's with Children's Hospital. He's a board certified pediatric infectious disease physician who is vice chair of education for the UC San Diego Department of Pediatrics and the program director for the UCSD Rady Children's Pediatric Residency Program. He's also an associate editor for the 2021 American Academy of Pediatrics Red Book, and that is a report from the Committee on Infectious Disease of the American Academy of Pediatrics, which is a Bible that we use in pediatrics. Dr. Sawyer has served on the CDC's Advisory Committee for Immunization Practices, and he currently serves on the Western States Scientific Safety Review Work Group on vaccines. Today's focus is the Tuesday, November 2nd COVID-19 update presented to the San Diego County Board of Supervisors. While the comments on COVID at yesterday's meeting were contentious and frankly at times, I'll just say offensive and inappropriate, we are going to focus exclusively today on misinformation related to the medical and health issues as requested by our Board of Supervisors. As I mentioned at the start of our first panel last month, the county has established a link on our longstanding COVID-19 website, coronavirussd.com, that is meant to assist the public in evaluating information on COVID. If you go to the website, there's a banner marked evaluating COVID-19 information. Clicking there, you can learn more about the different types of incorrect information, and there are links to credible sources. Some false claims have been paired with facts, as well as frequently asked questions. When we're done this evening, this session will be posted on the website alongside our previous panel, and we will update the website as needed when new issues arise. With that introduction, somewhat long, I'm sorry, I'd like to start with Dr. Sawyer, who is our only repeat expert from our last panel. There were quite a few public comments that came up yesterday about the safety and usefulness of the Pfizer vaccine in children 5 to 11 years old. And that is certainly in the news because of the recent CDC authorization. I wonder, Dr. Sawyer, if you could start off with a discussion with why children do need COVID vaccines. And I'll just warn people that you're the only one with slides, and that's the good thing, and we'll get through those and then we'll have a discussion.
Thanks very much, Dr. McDonald. At the moment, I don't have slides because it says the host has disabled my screen sharing. So if that can be fixed, I will show slides. Otherwise, I'll just talk about this topic. So this is an exciting day for pediatrics, as many of you probably have heard. The Pfizer COVID vaccine was recommended yesterday for children age 5 through 11, and vaccine has already started happening here in San Diego and around the country. So I think it's a really significant step forward for us in pediatrics, as well as controlling the pandemic generally. So here it looks like I'm going to be able to share my screen. Hopefully you're seeing a COVID vaccine, and I'm going to jump to the main question that, is on everybody's mind. And do kids really need COVID vaccine? So I hope to make a strong case for that, because I certainly believe it personally. And I can tell you the American Academy of Pediatrics, which is made up of 50,000 pediatricians across the country, strongly endorse vaccination of young children. And here is, in summary, the rationale for immunizing younger kids. First of all, they do have a significant burden of disease. And in fact, we've learned over the summer that children are just as likely to get infected with SARS-CoV-2 as adults. It is true they're generally not as sick when they get infected, but a subset of them are. In fact, there have been more deaths in pediatrics from COVID than we typically see in a year from influenza. In addition to that, children get this unusual inflammatory syndrome called MIS-C, which causes permanent damage to multiple organs. And that has occurred in several thousand children across the United States. Children are getting long COVID or prolonged symptoms after COVID, which causes disability over a longer period of time. And then, most importantly, kids need to be in school. And I think vaccination of the younger group is going to help us. So here are some numbers, if numbers work for you, millions of cases, 8,000 hospitalization, 94 deaths in the United States. This is simply between age 5 and 11. So that's 94 parents who had to bury their kids because of COVID. So it is not correct to say that kids don't get severe illness with COVID. This is just a slide comparing influenza to COVID. And most of these slides came from yesterday's ACIP meeting. So this is national information. These are two networks that survey flu and COVID. And the point here is that kids are getting put in the intensive care unit, getting put on ventilators more commonly with COVID than they do with influenza. And influenza is a disease we've worried about for years. Here's a graph of the deaths in pediatrics. You'll see a spike in the first year of life, a spike in late adolescence. And yes, the rate is lowest in the 5 to 11-year-old, but if you add up all those columns, it's not a trivial number. And just to finish that theme, COVID is now the 8th leading cause of death in children between 5 and 11. So I think the trap people get into is they compare adult COVID to pediatric COVID. Adults are dying in much higher numbers, but kids between 5 and 11 are not supposed to be dying at all. And unfortunately, they do for the reasons listed here, but COVID has made its way up to the 8th leading cause of death. I'm going to skip over the MIS-C thing and just point out this is a summary of a study from England showing that 7 to 8% of children who got COVID have had prolonged symptoms for more than 12 weeks. So so-called long COVID, which can be quite disabilitating with fatigue, headache, trouble concentrating, and presumably poor functioning in school. Speaking of school, this is a summary of school closures just this fall between August and October across the United States. 2,351 schools have had to close at least temporarily because of COVID. And this has been a major problem. We have learned that children suffer significant mental health challenges when they're not in school, when they're not socializing, they're not exercising, they get obesity. There's all kinds of complications for not being in school. And here's a list of other things that are happening. We've seen a surge in mental health illness in young children. There's disparities in education gaps. Some people can afford to hire private tutors, others cannot. Decreased physical activity, as I mentioned already. We're getting behind on routine immunizations because kids are quarantined and not going into their doctor's office. They're losing their family members. So for all these reasons, I think it's compelling to say that kids do need the vaccine. Then the next obvious question is it safe in children? I want to emphasize at the moment, we're only talking about the Pfizer vaccine. That's the only vaccine that's been approved and released by FDA and recommended by CDC. It is a different dose. It's 1/3 the dose than the dose we're using in adolescents and adults, but it's otherwise exactly the same. 2 doses are needed 3 weeks apart, and it's recommended for all children between age 5 through age 11. Side effects look to be very similar to what we see in adolescents, maybe even a little less than we're seeing in adolescents. So there's nothing unusual about how kids react, younger kids react to this vaccine. It does work. Here's a couple of slides showing you the evidence from the clinical trial. They had 16 cases in the placebo group, 3 cases in the vaccinated group, for a vaccine effectiveness of 90% against symptomatic disease. So that's on par with what we saw in older kids. I want to take a second to talk about vaccine side effects and how we know about vaccine side effects, not just in children, in adults as well. And I particularly want to have people become aware of the limitations of VAERS, the Vaccine Adverse Event Reporting System, that so many people talk about and quote numbers from, but VAERS is not a system that accurately tells the story. The way VAERS works is anybody can report a purported side effect without any medical evaluation or any clear indication about whether the side effect is related to the vaccine or not. And just because one thing happens after another thing doesn't mean that the first thing caused the second thing. So just because something happens the day after you're vaccinated doesn't necessarily mean the vaccine caused it. Many VAERS reports have errors in them. People are encouraged to report to VAERS, so it's a good system for signaling, but when people talk about an increased rate of VAERS reports, that's because we're stimulating that by asking people to report. You'll often hear people talk about deaths in the VAERS system related to COVID vaccine. Keep in mind that we're giving COVID vaccine to millions of people, some of whom are 80 or 90 years old, and people who are 80 or 90 end up dying every once in a while. And as a result, it inflates the numbers greatly. So again, I just don't want you to rely on the VAERS system. Instead, I want you to know about the 2 right-hand projects, the VSD, Vaccine Safety Data Link, and the Clinical Immunization Safety Network, or CISA. These are 2 systems, national systems, that are set up to monitor and really test whether a vaccine causes a side effect. I don't have time really to go into the details, but those are the numbers that we should be concentrating on when it comes to deciding what side effects are. So having said all that, we do know there are serious side effects from COVID vaccines. Allergic reactions, blood clots, Guillain-Barré syndrome, which is a neurologic condition that leads to weakness in your arms and legs and trunk. And then myocarditis, that's what's gotten the most publicity, particularly around the issue of pediatric vaccination. Myocarditis is an inflammation of the heart muscle. It is a recognized side effect of the mRNA vaccine. We have seen it in adolescents, including here in San Diego. But I want to assure people that it's exceedingly rare, unlike the hospitalizations and heart problems from COVID itself. So the risk of myocarditis from the vaccine is much lower than heart problems from the from COVID itself. And just to emphasize that point, there have been no confirmed deaths from vaccine-induced myocarditis in the United States. And as I said earlier, there have been 94 deaths from COVID itself in pediatric, just in 5 to 11. So that's all I wanted to cover, just some things that I know are on people's minds. Last thing I'll say before we go to open discussion is that I encourage parents who are still concerned about COVID vaccine or unsure to talk to your child's healthcare provider. They can give you the best and most unbiased information about whether it's in the best interest of your child or not. And with that, I will stop sharing and turn this back to Dr. McDonald.
Thanks very much, Dr. Sawyer. I'm glad you mentioned the issue of influenza that was brought up at yesterday's meeting, and for some reason, referring to influenza was being used as an excuse not to get the COVID vaccine, when frankly, the best conclusion is you should be getting both vaccines, because everyone over the age of 6 months is eligible for the flu vaccine today, and really they should be doing both. And that's not an argument to not get COVID. And also, thanks for going over VAERS. You did that at our last panel, and that was brought up a number of times yesterday, in which people were concluding that this database, showed causation, when you have shown that this is exactly not the thing to do. In fact, there's a warning on the website even before you can go into the database that says you understand that this database is not to infer causation. So it's very unfortunate that people keep making that mistake. So we have another pediatrician on the group. I don't know if you wanted to make any comments, Dr. Geary, before I started asking some questions, but oh, and Dr. Corrett is back with us too. Can you hear us?
There we go. Yes, I can hear you.
Okay. Wow, that's great. I gave an introduction already, so I'm just going to launch right into you're just perfectly in time. Dr. Sawyer just gave a talk, and I'm going to ask some general questions, which I'll maybe I'll start with Dr. Geary first, if that's okay. Some patients have expressed concerns because they keep hearing these COVID vaccines are new and they wonder how they work. And misconceptions came up about that. How do you talk with your patients about the COVID vaccine?
Good question. And we do hear this a lot from our patients. And basically I tell them, I said, although the vaccine came out fairly recently, the technology or the research behind it is decades old. It's been studied for a very long time, and timing is everything. Scientists have studied this type of technology, and then and they've used it for Zika and flu and other types of viruses. But when COVID came around, they were able to expedite this research and use the technology to produce the vaccine as quickly as possible, and with very good results. Typically, when we talk about vaccines too, it's always in the setting of obviously an appointment, and during that time, we're usually talking about other vaccines. And so we approach the vaccine very similarly, ask them if they've had it, if they're interested, if they haven't, and if not, why. And typically, we actually would talk about why would they have a different approach to some vaccines. Usually, they're no problem with, sure, give me the flu shot, give me the tetanus shot. Wait, COVID? I'm not sure. And so we go through and answer the questions that come up. But in terms of the technology, we just explaining the history, I think sometimes makes a huge difference. And then talking about how the vaccine actually is just using our basic body's infrastructure of making proteins and taking advantage of our body's innate immune system to generate antibodies for protection. So it's really using our bodies very smartly to have protection without actually having to get sick to get that protection.
Dr. Aldis, any comments there? She may have stolen your thunder, but I'm going to let you go ahead and comment.
No, I'm glad to have the thunder stolen because I gave that talk about 3 times this morning in my clinic. So, my voice is tired, but it's an important talk. I think, there's some excitement about these vaccines because they're so effective. And we were in such dark days, and they came and they really saved so many lives that the talk about them is a lot about newness. And I think that some of my patients just think, well, whoa, I'm a little afraid of something new, that isn't maybe studied or isn't researched. And so one thing I find is that when I actually talk to folks, I sort of try to bring it back down to like, I know it's exciting and we all like to talk about new stuff, but actually how these vaccines work to protect you is really not that new, right? Since the dawn of vaccines, we've been chopping up viruses or chopping up bacteria, giving it to your body and letting you produce a response, an immune response to protect your body when the real thing shows up. And that's still what these vaccines are doing. So I think that in some ways, because of a lot of the excitement and how effective these were and how we improved upon that system with these vaccines, there's been a sense that how they work is so different that it might not be safe. And in fact, what they're doing is really producing that immune response, and even the post-vaccine effects. So I had patients ask me about that. I said, yeah, you know how I always tell you, I'm a vaccine doctor. I always tell them, I always tell you that we're giving you a little piece of the virus or a piece of the bacteria so your body can produce antibodies and protect you when the real thing comes along. And that process produces some inflammation and you might feel something. This is the same thing. So when I relate it to our conversations we've had about other vaccines and they understand that, they say, oh yeah, you've told me that before, that I might feel some inflammation because my body's producing antibodies. Most of the patients know that they want to produce antibodies to protect them when the real danger comes along later. So I'm glad to kind of have that in this conversation, because a lot of people who have concerns about the vaccine, it's really because of that sense of newness. And so when I tell them, these vaccines were studied just like any other medicine has been studied through the same process. And in fact, what they're doing, yes, it's an improved technology, but they're still really just getting your body to look at a piece of that bug, produce an antibody response, and be ready when the real thing comes along. And so I think once they hear that, quite a lot of people feel reassured.
The other thing you can say about newness is, we have given these COVID vaccines to over 200 million people. We know a lot more about these vaccines than we've ever known about any vaccine in this first year of use. And so I think people should be reassured that the safety is being studied every single day. And that's why we know about the rare side effects, is we've been watching and paying attention.
Dr. Curette, any comments or any thoughts on that with your patient population?
Yeah, so very similar. I like to explain to them that the technology itself is not new, just as everybody else had said it. But I explain it to my patients that it's a recipe that's just being delivered that just produces a little part of the spike protein, and then it creates that immune response. And once you do explain that process, it helps them a lot. And then for my patient population, what I give as an example why it went so fast, I like to use an example of planning a wedding, or in my Latino population, I say a quinceañera. Usually you need a whole year to do that, right? And a lot of them agree. And I say, imagine if you took away you having to work, having to cook, having to do all the other stuff. There's just money available. You have time to do it. You can plan a wedding or a quinceañera in less than a year, in 3 months. And they're like, oh, that makes sense. I'd go, well, that's basically what happened. Things were pushed aside. There was money available, so things were able to just move along, but the check boxes were all still checked off. And that provides them some reassurance. Oh, okay, I get it.
No, thanks. That's a great example. And this is not gene therapy. This is the people who get a vaccine are not contagious to other people. I mean, I think that those are things that we just need to just say, because they just are true.
I think it is. I mean, just to be fair to that misunderstanding, I think partly, sort of putting the perspective of someone who feels cautious or nervous about the vaccine, they've heard a lot in the media about the technology, about mRNA, about DNA, and so I do think it's reasonable for people to have that concern. And so that's why, like Dr. Sawyer said, talk to your doctor. They can explain to you these vaccines work just like these other vaccines, and what they produce is the same. They don't integrate into your DNA. It's not gene therapy. And that is really reassuring to hear. But I think that I want to at least give understanding to folks who've heard that and felt nervous, because it's like, well, I know what mRNA is. Is this going to affect my DNA? And so I think that that's an important one to really get out there, is to help people understand that it's not the same, but the language can be confusing.
Yeah, that's really an excellent point. I appreciate that. Thanks for bringing that up. Maybe I can go around the horn on this one. When you have an outpatient with mild to moderate COVID symptoms, what treatment do you advise for them? Maybe I'll start with you, Dr. Aldis, and then go around again.
Yeah. So first of all, this is a vaccine panel, so I'm just going to remind people that the best way to prevent having to come to the doctor sick with COVID, or and certainly the best way to prevent hospitalization, is to get your vaccine so that we don't have to have this conversation. I'm really trying to make sure, actually, with all of my, especially my patients who aren't vaccinated yet, I talk to them about monoclonal antibody therapy before they get sick. Because if somebody has risk factors, especially somebody who's older or has coexisting conditions and has a risk factor to maybe they get COVID and it feels mild at first, but then the second week they get sick and they land in the hospital, the best option besides vaccination to prevent that is we have monoclonal antibody therapy that you want to give early to help protect you from going to the hospital later. So that's the one education I do before people get sick with COVID. Unfortunately, when people, once they are sick with COVID, besides early monoclonal antibody therapy, we don't have a ton of great treatments, but there is something coming down the pike for treatment. But since I don't have it yet, what I'm really doing is talking to patients about prevention with vaccines, and then awareness to call right away if they have any symptoms, so that we can get them tested, or they can home test and get them straight to monoclonal if they need it.
Sure. Either of our other panelists want to weigh in on that?
Yeah, well, I can comment as far as being a pediatrician with the kids. So I get a lot of the parents that call me for testing, and they're concerned if their kids test positive. But with children, most of the time, it's just supportive care. But I've actually had one pediatric patient that I did send him for an infusion because he had difficult to control epilepsy, and he met the other criteria and he was above 12. So I have used that for a child. But I feel as a pediatrician, also the other role I play is when this parent calls me about their child, I actually ask who else is in the household. I want to know all the adults that live there, because they usually live in a communal setting. And at that time, there's usually other adults, several family members. And I also talk to them about getting the antibody infusion. And I've referred several of them, so that way the grandparents, the aunts, the uncles, or whoever else is in the home is safe as well. So within just being a pediatrician, you can actually work on different levels to help the entire family, and plus even community, because then they're telling their family members as well if they had been exposed.
And I can chime in from the internal medicine perspective. So I think very similar when we actually get notification that the patient has tested positive, and sometimes they get tested positive outside. So they're coming to us after they've gotten the results from an outside center. And same thing, we offer them monoclonal antibody. We have an automatic screening system. As they qualify, somebody will outreach and actually talk to them about the risks and the benefits. But I actually talk to them as well about who else has been exposed, and do they need post-exposure prophylaxis, because we know there's actually a treatment for those patients, particularly if they've been not vaccinated. But also, this is the ideal time to talk about what are they doing? Are they quarantining? How are they staying safe? How are they keeping other family members safe? What symptoms to look for, whether they have symptoms and it's getting worse, or if they don't have symptoms and what would develop. And then, of course, vaccination. If you haven't been vaccinated, then now is the time, if you have not gotten it yet, to actually go and get those family members vaccinated.
It just dawned on me that the monoclonal antibodies is yet another reason for vaccine in the younger age group, because as Dr. Corrett mentioned, they're only available down to age 12. So we can use those in children with risk factors, but below 12, we can't. And so those kids really need to get vaccine, because that way, as Dr. Alda said, we won't be having a conversation about how to treat.
I think I don't know if you wanted to keep going down this road, but I have also heard sort of the monoclonal, which is I'm so glad that we have it and we're promoting it. But as like, well, I don't need a vaccine because there's the monoclonal antibody out there, and it's really not a replacement for the vaccine. The vaccine is so effective in preventing COVID that it's not really reasonable to wait until you get sick and then say, well, I'll try monoclonal antibody. It's not 100% that you'll have access to it. And one of the sad things about COVID that I think people don't always realize is that a lot of times people feel mild symptoms early, and then it's the second week there's this decline, and it can be very scary. They land in the hospital, and when you see these sad cases, a lot of times people didn't seek any treatment early. They say, oh, it was just mild. I felt okay. I didn't need anything. And then later, especially if they're, older folks in the house, if this is your grandma, later they land in the hospital. And so I think that the idea that I'll just wait for it to come along and manage it when it arrives is just too risky, especially for your vulnerable loved ones in the household.
Dr. Aldis, you raise a really good point. I think recognizing that the monoclonal antibody is not intended to cure you or make you better, it's to prevent you from going to the hospital and getting really sick. So we have providers who actually specifically screen patients who tested positive to see if they qualify for monoclonal antibody. And the vast majority, if they have been vaccinated, they're so grateful they have. But the vast majority who are not vaccinated, which is most of the people we're testing and coming up positive, they're really sorry that they didn't get it sooner. I mean, they tend to be much, much sicker because they have not been vaccinated.
I think it's important that you have these conversations with the provider, that especially people who are at increased risk for poor outcomes from COVID. And again, you've all talked about things that work, and unfortunately, at our supervisors meeting yesterday, people were throwing out lots of things that don't work, and everything from ivermectin to zinc to other therapies. And I don't know if you've ever had patients that have come in on those thinking that they work to prevent it, or that they think that that's something going to help them early on in the course. But no, the message is those things are not going to work. They're not evidence-based, and really, you need to talk to a clinician who can tell you what, in fact, are things that work. And going back to the original comment about vaccination, I think is critical. I wonder if any of you can comment about San Diego patients that have had COVID in the most recent surge of cases. I think that a lot of people sometimes think about COVID and the first reports they heard about it early on, that it was something that only people over the age of 80 got, and only people in nursing homes. And you're seeing patients now. I wonder if you can tell us who those people are and how they were exposed.
Well, I'll start off with kids in the hospital just to continue my theme of illustrating that kids are getting sick. So we have admitted, as I mentioned earlier, dozens of kids to the hospital and some intensive care. Most of them don't have significant risk factors other than obesity, which is the major risk factor in children, and some of them have asthma or other respiratory conditions. And so this is not just happening in kids who have, lots of medical problems. These are otherwise healthy kids who may have just a couple of risk factors. And those risk factors are important, including when you consider the monoclonal antibodies. But I just wanted to make that point about sick kids in the hospital.
I can tell you from, oh, go ahead, Dr. Geary.
Oh, go ahead.
I think we both wanted to jump in and talk about adults because we're internists. And of course, adults are the population that gets the sickest from COVID. And I think that in my experience, patients are often not aware of their own risk factors, right? So they might think, oh, that's only for grandma and grandpa. And they may not realize that, 40 and I'm 50, I feel young, but actually I'm on that other side of higher COVID risk. When you add diagnoses like diabetes or hypertension or obesity or smoking or other risk factors, people don't realize that they might be in that higher risk category. So, and then, you ask kind of who we're seeing now. One of the reasons why I, do this panel, or why my clinic runs late, because I talk to my unvaccinated patients for a long time, is because of the disparity in who's getting COVID right now and who's getting really sick from COVID right now. So, I think you may have said in the opening, the hospitalizations, I think it's 98% since January or something of the hospitalizations are among unvaccinated people hospitalized with COVID. I think at the moment it's 95, it's always in the high 90s. And so that is such a huge disparity. And so, who is getting sick from COVID? It's our patients who aren't yet vaccinated and their families. And I've had some really heartbreaking stories from families of, it's usually a family gathering and with multiple family members getting ill, getting sick. And I've had a few patients lose a family member that way. And it's a very painful thing for everybody involved. It's really, it's difficult for them to talk about. It's difficult for me to talk to patients about it, but I use those stories to share with my other patients, because I say, I care about you and I don't want to have that happen to you or your family, or have your family have to suffer through that kind of experience.
Yeah, thank you for sharing that. And we're seeing similar things. I think in the very beginning of the pandemic, we were seeing people who are a lot older, but now the trend is definitely toward a younger population. I think that's because a lot of older patients had access to the vaccine and now they're vaccinated. And it's the younger population that are thinking, well, maybe I can wait. Maybe I'll think about it. Maybe I don't need the vaccine because I'm young and I'm healthy, or I'm healthy enough. And of course, the children, partly because some of our children have not had the ability to get vaccinated until recently. And so we're definitely seeing a significant trend. Similarly to Dr. Aldis and Dr. Sawyer, we're seeing mostly unvaccinated people, a very large proportion in the hospital, unvaccinated. There are breakthrough. So some vaccinated people are coming, but they tend to be the ones with comorbidities and sicker. And in terms of being vaccinated, just to kind of hit the point home, I have two patients, one who actually lost 4 family members and one who lost 5 family members from COVID. But these family members were in different country where they did not have access to the vaccine. And it really highlights the opportunity we have here. Here it's people who may have misunderstandings or fears or concerns, but we have a choice. And we're luckier than many who have not had that choice to get vaccinated. So just a little food for thought.
I wanted to jump in on the topic of breakthrough because people are saying the vaccine doesn't work, so why get it? And it is true that vaccinated people can get infection, but they don't end up in the hospital. So the vaccine is working extremely well to keep people out of the hospital and dying from COVID. So, it's not a perfect vaccine. You can still get infected, but if it keeps you from getting in the hospital, it's doing its job.
I just wanted to, we have a weekly report that comes out from the county, our COVID watch, and I looked at the numbers before our presentation here. And in the last 30 days, actually the median case, the age of the median case for somebody who's not fully vaccinated is about 29 years old, means half the people are under the age of 30. It's quite astounding. But for people who are vaccinated, they're actually a bit older. The median age of somebody hospitalized for COVID and they're not fully vaccinated is 53 years old. And that's, again, that's a decade younger than I am. So that's a lot of people under the age of 50 who are getting hospitalized. The median age for people who are vaccinated is actually 70, which speaks to a couple of things. One, these are older people with comorbidities, but these are people who actually are now eligible for booster shots when the time comes, and they should be getting those boosters according to the recommendations that we have. I do want to make a specific comment, though, that the local surge that we've had recently, if you look at where they're being exposed, over a quarter of them have a history of potential exposure in the school environment. Again, that speaks to the younger distribution of kids that are coming down with COVID now. And there was a specific comment that people who are in the hospital, the board meeting yesterday, people who are in the hospital and contributing to the numbers that the county reports are people who are not residents of the county of San Diego, and it's just not true. We don't report on non-residents, and specifically, there's the outbreak is not being driven by migrants. And even though we're a binational community and we have a lot of family ties across the border, that is not the dynamic that's going on with the current cases.
I wanted to comment just about I think you can hear in the voices of the doctors on here that this is also very personal to us, right? Because we care about our patients and, to see our patients getting sick and suffering. So when people say, oh, people aren't being impacted, it's really difficult for a physician who's treating this and helping families and getting the phone calls from families, in San Diego to hear that. It's just so blatantly untrue. And so it's just one of the ways that this has also been sort of emotional or difficult for doctors, because we're seeing those stories and we're seeing those patients in the hospital. And so when we hear this misinformation, we want to say, well, I can just tell you my personal experience is that that's just not the case.
Yeah, thanks for that. And, I'm just going to set up another question. It's maybe a little repetitive, but it's something that, again, came up yesterday. I wonder if somebody can explain why it's important to compare the rates of cases and hospitalizations and deaths as opposed to absolute numbers of cases in the community in order to understand how well vaccines are working. I wonder if anybody just wants to take a quick stab at that.
Well, I'll start with that. I mean, the rate takes care of the different numbers of the population in different segments or ages. So if you're comparing everyone 18 to 64 years of age and just counting how many cases you have, you're going to have a lot of cases because there's so many people in that age group. compared to, say kids under 1 year of age. That's just one 1 year cohort. So in order to compare, the same apples to apples, you basically need to break it down in numbers per 100,000 is typically done, but it doesn't matter. You have to make that correction in order to balance the numbers.
Yeah, the rate is for not fully vaccinated is 3 times higher for the cases, and it's 14 times higher for hospitalizations. And that number is true here in San Diego. It's actually repeated in other jurisdictions, and we have Dr. Wooten presented that in our graphs yesterday. And this is not a statistical trick. I mean, this is a way you can compare things to be fair about the populations. And again, this is something that some people at the board meeting yesterday were confused about. Dr. Geary, I cut you off. I didn't mean to.
No, you answered my point, but I was just going to add as an example, if you have a county that has 1,000 people and 100 people got sick, that's a 10% rate. But if you have a county that has 1 million people and 100 people got sick, the rate is very different, even though the absolute numbers are actually the same. And I think that's how you compare. Is you have to Dr. Sawyer's point, is the denominator makes a big difference. So you can actually really compare apples to apples.
And that's true for side effects too. I mean, you count how many people have had myocarditis, but then you look at how many people have been vaccinated, and the rate is exceedingly low.
Thanks.
Thanks for the example of.
Go ahead.
As I usually use the example of driving a car, because when people say, "Is it safe?" I'm like, nothing is 100% safe, but do you drive a car? And if you drive a car, is there a chance you might get a flat tire or run out of gas or get in a car accident? And most people drive a car. They drove a car to the appointment, but that's not 100% safe. But they have no hesitation about getting in the car and driving. And yet vaccines are much safer, I think, in many cases than driving in cars these days.
Let's extend that to kids and seatbelts. You put your kid in a seatbelt in a car seat. Why don't you give them vaccine to protect them? It doesn't protect you 100%, but it does a very good job.
Also, I was hoping, Dr. Sawyer, I think when you brought up, it's hard as humans, it's hard for us to compare risk. I would say, like, for me to be afraid of shark attacks, like that's doesn't seem reasonable, but there it is. So, humans have normal fears. It's understandable. But it's helpful sort of to compare things. So for example, with myocarditis, you're talking per million. So it's not very common and mild, but then I think you were in a presentation where you may have shown some data on the rates of myocarditis with getting the virus, with getting COVID or with getting other viruses. And so I think that some of that is helpful to put those comparisons in place. It's like the driving the car or getting COVID itself is often a really good comparison. So your chances of having all of these things happen if you get COVID are also much higher than with the vaccines.
Yeah, thanks for that. I know it may seem just relatively obvious, but there were people that were making this basic mistake, and there was even a data expert who was there who essentially made this mistake, trying to steer people away from understanding the real importance of using rates to actually compare numbers and compare risks. And one of the other errors that was made actually with data was that somebody made a calculation, and that's been repeated unfortunately in the media, that the absolute number of cases in San Diego have been higher in the vaccinated group. That's just not true, actually. There's never been a week and there's never been a day in which the absolute number of cases have been higher in the vaccinated versus the unvaccinated. And now it may be true that someday that happens when 99% of the population is immunized. I actually hope we get to that day, but that is not an argument that the vaccine doesn't work. And unfortunately, that's the kind of thinking that was demonstrated yesterday during the board meeting. I'm going to go on to
percentage. Sorry, I was going to say, I always use your website. I show it to patients in the exam room, and I always use the percentage because I feel like that one's pretty straightforward. So I say, look at the people in the hospital at the moment. I can't have my glass on. 95% of them, 97.8 on the website last week, are unvaccinated. So I feel like sometimes to help people really use a number that they're used to, I use the percentage and I show them your website, which I think is really an excellent resource for patients. And I say, here's all the people in the hospital, and they're essentially all unvaccinated. And that I think is helpful if people get stuck in a lot of the other numbers, because there is a lot of data out there.
Yeah, it is easy to get lost in that. I wonder if I could just change topics. I mean, I wonder if you can comment about what you advise your patients about using masks. I mean, I think that's a topic that comes up frequently, and just like to hear how you talk about that. Maybe we can start with Dr. Curette.
Yeah, so I always educate them. I think when I go in and walk into a room, I try to meet the patient where they're at. So if they have concerns and questions, and just say, hey, any question is valid. And as soon as I start talking, whether it's a vaccines or masks, I take that time to talk to them. And, I do get the question, do masks really work? And of course I say, yes, they do. And then what type of mask? And I really just tell, and I think, what within the AAP town hall series, when a lot of the discussion is, whatever mask your child will keep on is good enough. We try the 2 layers for the kids, but for the little ones, if there's one they like, but they keep it on, then just go ahead and keep it on. And, surprisingly, before the mask mandate, people thought, oh, the kids aren't going to want to wear it. And I will tell you, I don't really have any issues with any kids wearing it down to 2 years old. And then even the kids that have developmental disabilities like autism, they're wearing them as well. There's very few that have difficulty where the parents have come in to request a letter for school. And, I talk to the parents, talk to the child, and I work with them and work with the school because these kids have an IEP. So I ask the parents, why don't we write as a goal within the IEP to work on getting him or her to wear a mask or a face shield as well. So, and then I really don't get within the community health setting as far as like, is it going to impact oxygen, carbon dioxide? I really don't get that within it. But obviously, if that question does come up, I said, we've been wearing masks for a long time. Kids have been. You put that pulse ox or vitals, or it's all normal. So, but I haven't had backlash.
Thanks. Anybody else want to jump in on that one? I think that actually sort of pretty much nailed it.
Masks are extremely effective. The other thing I mentioned for people is that you're protecting yourself, and for things like children in school, if they have their mask on, they don't have to quarantine after an exposure if they're protected with a mask. So there's a lot of benefits to the individual. And I think that that's one way of looking at it too, is that obviously it's a community service to not be, protecting other people from my own germs, but it's protecting me as well. And I think for the patients and for kids are adaptable. It's the adults that have more difficulty. But they get a well-fitting mask. You look at the kids, they're out there playing, having fun. But it does prevent, and so, as does vaccination soon, prevent them from having to quarantine and things like that if they don't get COVID because they have their mask on. So there's a real benefit to it, to the individual.
I would add that I agree. Masks are safe and easy way to add an additional layer of protection against COVID and other infections. And I have 3 kids, and I can tell you that I don't have to tell them to wear a mask. They prefer to wear a mask when they're outside because they know they don't want to get sick. Kids are smart, and most of the time, if they have any issue with the mask, they'll, find a way to accommodate or change it. But I haven't had a lot of people actually have issues with masks.
Wow, thanks. There's a little potpourri here towards the end of our conversation here. Do your patients ask you much about natural immunity, and what do you advise them about getting vaccinated if they either have had COVID or they think they've had COVID? And I'll maybe start with Dr. Geary on that one.
Yeah, this is a very timely question because I think as the pandemic wears on, more and more people have had COVID, and I saw 2 people this week with this exact same question. What I tell them is that, you may have some protection, but it's unclear how much protection, how long, and I would still recommend a vaccine because studies show that you actually will have a more robust response. And there's nothing wrong with having an extra layer of protection. It's available, it's safer. So I don't have any issues with recommending it. Now, they may ask when to get vaccinated, and sometimes we have the discussion, I have COVID or I had it recently. How soon do I need it? Do I need the booster now? Do I wait? And I think we have that discussion as well. But definitely, I recommend that they get the vaccination.
Dr. Aldis, any thoughts? You were shaking your head like you had some extra things.
I do the same. I do the same. You know, I think that one thing that happens with people's interaction with doctors is, you know, doctors don't like to say, I don't know, and nobody likes to hear that. But sometimes we do have to say, we're not sure. We're not sure exactly when is the best time to get your vaccine after your infection. And so I try to be honest with people to say, I'm not really sure. I know that it's recommended and I think you do need it. I don't know if you need it immediately after your infection or if you want to wait 90 days, which is kind of that window that we say is a reasonable time to wait if you choose to. The official recommendation is that you need to be recovered from COVID and then you can get your vaccine. So that's what I tell people, is that this is the official recommendation, which means you can get it anytime. I can't tell you exactly the best time to get it, but I do want you to get it. And then we talk together about what works for them. They might say, you know what, I just had COVID, I'm going to wait and I'll do it at 90 days. Other people say, you know what, it was a really terrifying experience and I just want to be vaccinated and get past that and feel like I have that protection. Then they can go ahead earlier. So I think that that's how a lot of doctors are approaching those conversations, where it's not exactly sure the exact timing, and it's okay to say we're not exactly sure when, but we do recommend that you do it, especially when you look at the antibody response after having COVID and being vaccinated. And again, you know, that terrifying experience that many people have had of having COVID and really wanting to feel like they have protection from getting it again.
Yeah, there is certainly a lot we don't know about COVID, but what we have learned in the last year is the higher your protection levels, your antibody levels, the better off you are in general, and particularly against the variant strains that have emerged. And that's why we're giving booster doses, is to crank up the levels higher. And the same thing happens after infection. Your antibody levels go down over time after you've been infected, and getting the vaccine just pushes them back up so that you're extra protected.
You know, there were a couple of comments that were made in this last board meeting that frankly we addressed in the previous panel. And I'm just going to make a couple of quick statements. And if you want to go and talk about or learn more, if you're listening, I refer you to the other panel. And that is that the PCR tests that are used to diagnose COVID are reliable and accurate. The vaccine is safe, effective, and recommended for pregnant women and those women of childbearing age. And that the Pfizer vaccine has been approved by the FDA for those over 16 and over. And even though it's being marketed under a new name, it is FDA approved. And if you want to go into details on those specific things, I want to make those statements because the contrary was asserted yesterday. And I'll see if anybody wants to make a comment on that, but I just want to get those three out there since they were mentioned yesterday.
Yeah, I can comment. I get a lot of parents that ask me that, especially for their teenagers, because they're concerned about fertility and so forth, or even mothers who are breastfeeding. And, you know, I keep telling them it's safe, it's okay for you to go ahead and get the COVID vaccine. And then the benefits of even getting the vaccine for the baby as well, and even during pregnancy as well. I reassure a lot of parents that have the teenagers that I see a lot of mothers that have newborns that were fully vaccinated and their babies are thriving, they're doing well. We're not seeing absolutely any issues. So I think when you share a lot of the personal experiences that you're having with your other patients as well, the patients really take to it and listen to you. And it's just the trust that they have with their provider.
I want to briefly touch on FDA authorization because, as I made the point earlier, we have more experience with this vaccine than any other vaccine when it got FDA approved, even though we've been using it mostly under emergency use authorization. We've given it to millions and millions of people. Typically, a vaccine gets approved by the FDA after a few thousand people get it. So although it naturally causes you to wonder, it's with the name emergency use authorization, but the system is in place to find side effects and detect them, and we are detecting them accurately. So people should take some reassurance in our general experience with these vaccines by now. And in fact, I read somewhere that across the world, something like 6 billion doses of COVID vaccines have been given.
I'm going to go.
Joke about people saying like, I don't want to be first. I don't want to be a guinea pig. And I always say like, well, you missed that boat because you're not first. We're well into this now. So people who wanted to wait and see that's good. But now there's plenty of waiting that's been done and quite a lot of information to go on.
I wanted to go around the panel just one more time, and I've asked a bunch of questions, but we're running out of time. And if there was a topic or a misconception that your patients have that we haven't talked about so far, if you wanted to kind of get a quick potpourri in at the end also, just to say, hey, you know, this is what my patients are concerned about, and this is how I address it. I'll just maybe I'll start with Dr. Sawyer and then go around, and then thank everybody for participating today.
Well, I'm going to cheat because it's something we have already addressed, but I want parents to appreciate that it's in their interest to carefully understand the risks and benefits of these vaccines for their children. Now they can get them for children 5 through 11 years of age. I highly recommend that they do that, but if they have concerns, talk to their doctor.
Dr. Aldis?
Well, we've covered a lot. I have so many, but I'm going to put up 2 things. Number one, Dr. Tudor, who leads the monoclonal antibody, has requested that I didn't give the phone number for the monoclonal antibody. And we do want that in the recording, just back to our conversation about monoclonal antibody access. So I just want to read it since it's being recorded. It is 619-685-2500. That's 619-685-2500. So that's where people could call to get access to monoclonal antibodies. So I wanted to make sure that I said that and didn't disappoint Dr. Tudor. So as to your question, I think we've covered most of the main ones that my patients touch on. I was asked recently if getting the vaccine would cause a false positive test result. So we have excellent COVID tests, both the PCR and antigen tests. Those are looking for pieces of virus in your nose. So getting the vaccine does not produce pieces of virus in your nose, and therefore will not give you a false positive COVID test. So I was asked that the other day. And I think we've covered most of the other hot topics that I have been discussing in clinic. Thank you.
Dr. Curette?
Yeah, along those lines, I think this week I got, can the vaccine give you COVID? So again, it cannot give you COVID. There's no way. And I had to educate the parent that we don't do a COVID test prior to giving the vaccine. So there's a chance you just might already be a carrier of COVID and have it, but we just don't know. And it's like a light switch went off. Oh, that makes sense. So if you can just really honing in on that. And then the other thing, it's safe. I'm a mom and I tell the parents that, and I'm actually very excited about the vaccine. I have a 5 and 8-year-old, and I have their appointment this Sunday. So I'm really excited that they're finally going to get their vaccines.
And Dr. Geary.
Okay, great. So well, what I hear sometimes from patients is that they're worried about side effects of the vaccine and say, well, if I get it, I don't anticipate I'll get that sick, so maybe I'd rather just take my chances. And so I want to just emphasize that if you get COVID, not only can you potentially get very sick and get hospitalized and, you know, obviously potentially die from COVID, but in some cases, even if you don't get that sick, you can have symptoms that actually last for months and months afterwards, called long COVID. And up to a third or more people can actually get these symptoms of fog of brain or, you know, chronic cough, shortness of breath, weakness. There are a lot of things that actually don't completely get better very quickly. And so, whereas the side effects from the vaccine typically resolve very fast. So it's not a good reason to not get the vaccine. And actually a reason to get the vaccine is to prevent potential long-term symptoms like long COVID.
Yeah, two of my patients this morning were concerned about side effects. So I rebrand side effects and say those are post-vaccine effects, and they show that it's working. It's inflammation, right? And once I explain to them how the vaccine works, and I say, of course, you're waking up your immune system, making antibodies. You're going to feel something. That's it. That's the vaccine at work. And so that was 2 of my patients this morning were afraid of the side effects. And so I think when we really explain that those are post-vaccine, the vaccine at work, that does help people feel more comfortable, especially when you, right, as you said, lay out all the negatives of getting COVID itself.
Yeah, I was really.
I tell them it's a sign of a strong immune system.
Sorry, I spoke over you, Dr. Geary, but I said I was really happy when I felt crummy the day after my vaccine because I knew it was working.
I mean, that's almost a good note to end on, but I'm not going to end on that. I'm going to actually thank you for participating today. Doctors Aldous, Geary, Corrett, and Sawyer. Just really just so appreciate the time that you've taken away, valuable time away from your patients to do this. I also want to thank our two translators, Tanya Flores and Carolina. I don't have her whole last name. Villamarin. Okay, I'm sorry, got there. I want to thank you for doing these translations for us today. And I think our session today is concluded. I hope you will go to our website, coronavirus-sd.com, and learn more. But again, thank you so much, panel participants. This was a successful evolution. Thank you.